we surveyed 18 to 30-year-olds, and 42% of those who responded to our survey did not know that dementia is a life-limiting illness. If somebody is diagnosed very late into the condition and they're no longer able to make decisions or have those conversations, that can really impact on actually the care experience.
It's being termed as the long goodbye, as that's kind of the experience that people who are caring for those with dementia, that kind of sums it up for them, that the person that they know is changing so much that they're seeing them almost disappear before their eyes. Hello everyone, and welcome back to the Mental Wellbeing College. Today we are joined by Dr. Nuriye Kupeli to discuss all things experience of caring for someone living with dementia. Dr. Kupeli is an Alzheimer's Society Research Fellow and a Senior Research Associate with the Marie Curie Palliative Care Research Department at University College London. In today's discussion, expect to learn what some of the challenges are associated with caring for someone living with dementia, why today's young people are expected to be affected by dementia more than ever before, why dementia is often termed the long goodbye, the importance of person-centered care for people living with dementia, and much, much more. If today's episode of the Mental Wellbeing College has brought value to your life, I would be super grateful if you were to hit subscribe or follow, as this is how we continue to grow the show and provide a free, accessible resource on evidence-based wellbeing strategies to people the world over. Before we dive into today's episode of the Mental Wellbeing College, an important forewarning. In each episode, we do discuss and dive into the weeds of mental health. This means that we cover sensitive topics like suicide, self-harm, addiction, and mental illness. If this facilitates distress in you, please do seek the support that you need, including professional help. Whilst this podcast does discuss plenty of evidence-based strategy and goes into the weeds of the research, this is not intended as a substitute for professional support, including therapy and other forms of psychological treatment. Welcome to the Mental Wellbeing College, where we take a deep dive into the wonderful world of mental wellbeing. Each episode, we take a journey through the evidence with a global subject expert to extract the applicable strategies so you can take steps to improving your mental wellbeing. And we're going to be talking all things dementia, which is obviously a really important topic given prevalence rates are quite high. I think I was reading 50 million people globally, it's estimated, have the condition at the moment, and it's only expected to double, if not triple, in the next 20 to 30 years. But before we get into kind of the nitty-gritty around dementia and the care experience, I'd love to know a little bit about your story, Nuriye, and how one goes from cabin crew at Virgin Atlantic Airway to researching into dementia and palliative care.
I'm a Principal Research Fellow here at Marie Curie Palliative Care Research Department at University College London in the UK. Mm-hmm. And in terms of my journey, I haven't had the most sort of, I'd say, straightforward of journeys to dementia research. I sort of did my A-levels here in the UK, and then I decided to take a little break. I thought, what can I do? I wasn't sure what I wanted to do. I wasn't sure if I was going to go to uni or what I would even study at university. So I ended up, like you said, become cabin crew for Virgin Atlantic. I did that for just under 3 years, and it was a great experience. And then I sort of got to a point where I was like, maybe now I'm ready for going to uni. I did an undergraduate in psychology. To be honest, actually, I went to university because I wanted to become a graduate manager for British Airways. And to be able to do that, you needed a degree. And actually, and then I went to uni and then never left, really, essentially. I did my undergraduate degree, I did my master's in research methods, and then I did a PhD in health psychology, actually, not dementia. I did a PhD looking at eating disorders and weight regain following weight loss following obesity. So very different to what I do now. But actually, it was what I did during my undergraduate that inspired me with dementia. Mm-hmm. So I worked with a cognitive psychologist as part of my undergraduate dissertation, and we looked at memory markers that might indicate that somebody might be at the early stages of dementia. And it was really through talking to family carers in memory clinics that once I'd finished my PhD, I thought actually it was dementia that I really, really enjoyed, and I really enjoyed working with people living with dementia and their carers, and it sort of resonated with me really. And then that's how I ended up where I am now. I got a research fellow post here at UCL looking at improving the end-of-life care experience for family carers and people living with dementia. And then I was successful in getting an Alzheimer's Society fellowship, looking at developing an intervention for family carers. So that's how I sort of got to where I am now.
Yeah, quite a really interesting journey, and it sounds like you've ended up somewhere completely different to where you thought you would when you started out on your journey. Yeah,
definitely not at British Airways.
Yeah, something very different indeed. So obviously you research a lot, Nuriye, now on dementia, palliative care, and if I'm honest, dementia is a term I have heard a lot about, but it's not one prior to researching through your work that I had much knowledge on at all, and still don't. So can you tell us a little bit about what dementia actually is?
Actually, what you're saying is very, very common in terms of the generation that are going to be most affected by dementia are the people who don't really know that much about it. I'll just give you an example before I go into what dementia is. We did a YouGov survey here in the UK, and we surveyed 18 to 30-year-olds, and 42% of those who responded to our survey did not know that dementia is a life-limiting illness. And it's such a misconception that, that of course people can live well with dementia, but I think the issue is this is where the difference between sort of other life-limiting illnesses like cancer or organ failure is that dementia is sometimes incorrectly viewed as being part of normal aging when it isn't. So obviously we know that dementia is a progressive neurological condition, it's life-limiting, so basically it means people will die with dementia. There is at the moment no cure. They will either die with it or from it. Dementia it's an umbrella term for different types. So within that umbrella term, there's things like Alzheimer's disease, vascular dementia, Lewy body dementia. You also have frontotemporal, which is referred to as young onset. So they're people who are diagnosed with dementia before the age of 65. So there's many different types, most common being Alzheimer's disease. Overall, what it is basically a neurodegenerative condition where it's basically caused by abnormal changes to the brain. And as a result of that, what happens is it affects people's ability to be able to think and to be able to recall memories, and even their social abilities. We know that the onset of symptoms can differ from person to person, but it's most commonly characterized by things like general forgetfulness. And I think this is where the misconception comes in around normal age. And I'm getting older, of course I forgot where I put my keys. Whereas actually those sorts of symptoms tend to become much worse, to the point where people can become quite confused. They find it quite problematic or challenging to find words and have conversations with people. Sorry, did that answer your question?
Yeah, definitely. It seems like it can be very variable in terms of the presentation that someone has with dementia, right? It's almost like a catch-all term for severe kind of cognitive impairment as you get older. Is that a fair kind of summary?
Absolutely, yes, exactly that. So it is characterised very much by cognitive impairment, but how that sort of materialises or presents is very different.
Yeah. And in terms of that variability, it seems like as well with dementia that it's very unpredictable how these symptoms will manifest or what the prognosis of someone with dementia will look like, right? That varies very much person to person, how someone or when someone will develop certain symptoms, when they will get to end of life.
Absolutely, yeah. And this is what makes dementia diagnosis very, very difficult and challenging. We know that actually a lot of people don't tend to get a diagnosis until much later on in the disease progression. Actually, the latest research here at UCL shows that it's around 115,000 people in England go undiagnosed. So they just don't get a diagnosis. And the impact of that is that they actually, family carers and people living with dementia experience it and sort of live through that without getting any support. And that's the issues, and that's what we're trying to improve, is being able to make sure people get a diagnosis in a timely manner, so that not just the person living with dementia, but also their family carers can access the right support. But going back to sort of this idea around not considering that it's a life-limiting condition. So if for example somebody gets a diagnosis of dementia, they don't instantly sort of have access to palliative care or the things that might help with improving care at the end of life, things like around advanced care planning and making it, or having conversations around what somebody may want at the end of life. And so actually because if somebody is diagnosed very late into the condition and they're no longer able to make decisions or have those conversations, that can really impact on actually the care experience.
So why is it that so many people, you said 115,000 people in the UK are undiagnosed with dementia? Why is that? Is that because, coming back to what you said earlier, they feel like the symptoms are just part of a normal aging process, or what's going on there?
Through talking to family carers, we hear that a lot of family carers say, the person I'm caring for, my mum, my dad, my partner, they don't recognise that they've got dementia, or they're refusing to see a healthcare professional to be able to get a diagnosis. And so actually it becomes quite difficult. And as the disease progresses, and we were talking about around the uncertainty around the trajectory of dementia, and as the disease progresses, it becomes harder for that person to get that diagnosis. So a lot of the times people just say they've got dementia, or it's possible that they then have other comorbidities, and they may have other conditions that may then obviously that they may die with before they get a diagnosis of dementia too.
Okay, so even just diagnosis itself, let alone treatment or caring for someone, is a very difficult process by the sounds of it, and one there's a lot of grey area around. If someone was to get a diagnosis of dementia, what's that process like? Is that just a simple visit to your GP? That's the term for general practitioner. I don't know what the equivalent is in the UK, but physician in America. Is it just a simple case of going there, or do you have to get like a neuropsychological test or a brain scan?
It's not straightforward. So commonly the first sort of place of call is your GP. As you said, same thing here in the UK. Right. If the GP feels that yes, there may be something going on here, they will refer to what we call memory clinics in the UK, where you'll see a consultant who specialises in older age adults, and then they will do various memory tests. Then they may do some neuropsychological testing, and then yes, they will have. It's more than likely that they will have a brain scan to see if there are some abnormalities in terms of changes to brain structure, and then at that point it's confirmed whether or not somebody has a diagnosis. And I guess it's that first step of getting to the GP is what a lot of people find quite difficult. It's what we hear from family carers is saying, I try to encourage them to go to their GP, to see their GP, to say, look, there might be something going on here. And it's that sort of refusal, or maybe it's possible that the dementia has progressed and they're not able to think in a way that allows them to say, actually, maybe there might be something going on here. Maybe I do need to see a healthcare professional.
Do you feel like, because it is such a progressive and a lifelong illness, that there is an element of denial or not wanting to have that diagnosis, even though you suspect that something's going on within the person themselves, but just not wanting that one word, the diagnosis of dementia?
Absolutely, it is, but it's still very much stigmatized, despite the fact that we have come a long way and we know a lot more about dementia now. There is still a sort of a stigma element to it. So if you've got an older adult who's maybe got friends and family, and they don't want to be labelled with a diagnosis of dementia because they feel that people may view them in a different light. A lot of people may not want to lose for example, their independence, although it's not what always happens, but it could be that this is a fear that people living with dementia may have, and that's why they may avoid seeing a healthcare professional or seeking a diagnosis.
Yeah, okay. And I know obviously you've done a lot of research, Nuriye, on the carer experience and some of the challenges that those caring for people with dementia go through, or those living with dementia go through. I've heard, Nuriye, it being termed as the long goodbye, as that's kind of the experience that people who are caring for those with dementia, that kind of sums it up for them, that the person that they know is changing so much that they're seeing them almost disappear before their eyes. And obviously, coming back to the variability, we talked about every experience is different, but is that something that you see pop up speaking to carers, this element of having to say goodbye to someone before they even physically pass?
Yeah, absolutely. So as we said, with the trajectory of dementia, everybody, people could live 10 years or even longer sometimes, but actually over those 10 years, a lot of changes take place, and there's a lot of key milestones that may happen in terms of, we talked about it starting off as sort of memory problems, forgetting where you place things, some confusion, then it might progress to not being able to find your words, or it may impact your social functions, and then it sort of progresses to forgetting your loved one, so not remembering, say, who your partner is, or confusing them for somebody else. And actually, while in this whole process, what family carers tend to say is, yes, I've seen them go through all of this where they've forgotten who I am. They're no longer able to communicate with me. They're no longer able to be, social, or they've become, for example, the advanced stages of dementia is commonly characterized by becoming doubly incontinent. Some people stop talking. Some people become bedbound. So these changes, because the family carer views this over a long period of time, it is seen as the long goodbye. And I think this is quite important in terms of how people experience grief and why it differs in carers of people living with dementia compared to, say, carers of somebody who's diagnosed with, say, organ failure or cancer. Because what a lot of family carers say is, they say, I like you said, I had to say goodbye to the person before they had even died. So this idea around pre-death grief, they're experiencing grief not after the person has died, but while the person's still alive physically, but who's no longer able to sort of communicate or to be able to, or be the person that the family carers remember them to be as. And so what that can impact on is there's this idea around prolonged grief or prolonged grief disorder, and that's this idea that actually, family carers of people living with dementia are more likely to experience it, where their grief goes over a much longer period of time, and it can be quite complex. And that's also because, again, it starts before the person has died. Then you've got this idea around when the person actually passes away. And I think the other thing that also complicates their experience is, in comparison to other diseases or conditions, the person with dementia is no longer able to express their needs. They no longer express their wishes and wants. And so family carers have to, in some ways, second guess, especially those who have not been able to have conversations while the person was able to have conversations. And so, a lot of family carers, when they have to make difficult decisions around, say, whether or not to place their loved one in a care home, or if they become very unwell, do they go into hospital, and things around do not resuscitate orders. I don't know if that's the same thing in Australia, whether or not to sign one of those. And so if a family carer is unable to have those conversations before the person loses capacity, this can also complicate a family carer's grief, because they may question if they are doing the right thing, or if they may question, am I doing what they would have wanted me to have done? And so, even once the person has died, a lot of family carers tend to reflect back and say, I don't know if I did the right thing. I don't know if this is what they would have wanted me to do. And just going back to your sort of your comment around the trajectory of dementia being very variable, and actually not knowing when somebody's in the dying phase. And so what we don't know, and we're at the very early stages of this work, is around understanding, is there an indicator that somebody maybe in the last 6 months or a year, the last year of life, and that's to be able to in some ways prepare family carers, because that's what we're not able to do, is we're not able to prepare family carers for somebody dying. There's indicators of sort of the last weeks and days of life, when somebody stops eating, drinking, sleeping a lot, for example. Those we know, but by that point it's sort of too late. And it's been able to prepare family carers for that end of life journey, really. Even though they've begun that journey way earlier on, it's been able to say, look, yes, they are very much in the last year of life. You may have to make some difficult decisions. And that really can impact on the carer experience and their own well-being as well, and how they experience grief once somebody has died.
Do you prepare carers for the unpredictable nature of dementia in itself? Is that something that you find is helpful for carers to know at the onset that, look, we don't know necessarily the trajectory here or what's going to happen, and you need to prepare yourself for that?
I don't think we do it well enough, unfortunately.
Okay.
And this is what the research suggests, is that actually that's what we should be doing, is that as soon as somebody is diagnosed with dementia, that conversation around, this is now life limiting. Yes, you can live well with dementia. We're very much advocate for that. But the person you're caring for will die with dementia now. And not now, but they will eventually die with dementia because there is no cure. And we don't do it well enough. I think there needs to be a lot more resources, especially into health and social care practices, around having those conversations. The problem we find is around which healthcare professional is best placed to be able to have that conversation and to be able to gauge. Actually, I think the other sort of complicated issue or the challenge is gauging whether or not a family carer or even the person living with dementia is ready to have that conversation. So it's knowing that, if somebody's just been diagnosed with dementia, they're probably overwhelmed at this point. They go to a memory clinic, they're told, yes, the person you're caring for has a diagnosis of dementia now, and then they're sort of sent away with loads of resources, like loads of information. This is what dementia will look like. This is the sort of support they may need. And is that the right time to say, this is now a life-limiting illness? You may need to make certain decisions going forward. Or actually, is it sort of planting the seed at that point, saying, life-limiting illness, but when you're ready to have that conversation, come back and we can have that discussion. Because sometimes family carers also don't want to have that discussion at that point. Because I imagine, at that stage, it's a lot to take in. And that can be quite complicated.
Yeah, it seems like whoever the professional is working with carers and people living with dementia, sensitivity must be, such a consideration that they have to have in terms of timing of the conversation, the way you word things, the way that you convey and communicate things about the condition to people living with dementia and their carers and families. And
this is where we sort of advocate for the role of palliative care. Palliative care is all about the care of the dying. And that's not the dying, the imminently dying. And I think this is where, again, there is some misconception that people view palliative care as, oh, you must be imminently dying if you're seen by palliative care healthcare professional. Not at all. Actually, palliative care see people who may be diagnosed with a life-limiting illness, but who may live for 5-10 years. But, they come in as in when it's relevant, for example, things around symptom management, ensuring that somebody is not in pain or is not experiencing any distress, and being able to support the family carers. And my role as a dementia palliative care researcher is being able to advocate for that, is to say, actually, palliative care is really good is a really well-placed profession to be able to instigate those conversations and to have a role in dementia, from diagnosis all the way through to death and bereavement.
So what does that role of a palliative care professional look like, particularly in the earlier stages when someone may not be imminently dying?
It's usually commonly around sort of symptom management, possibly making advanced care plans. Plans, what would you like us to do? How would you like us to care for you if you were to become seriously unwell? It's really just around having those really difficult and sensitive conversations, really. And it's, I guess, in some ways, it's sort of setting up the not the environment, it's sort of setting it up to make sure that person has a good death at the end of life. Cicely Saunders in the UK was very much sort of the pioneer of the hospice movement around making sure that palliative care considers a person, from a person-centered making sure that you're looking at just not the person and the disease, but you're looking at everything that encompasses that person. Whether it's making sure their spiritual needs are met, whether it's their physical needs are met, whether or not their carer, the people that are caring for the person dying, is well supported. So it's very much looking at it from a holistic view.
So, Nuriye, if we come back to the carer experience specifically, what are some of the protective factors that you find really help a carer manage the really stark and obvious mental health challenges that someone may go through in that experience? What are some of the things that they can do that, in terms of supports from the research and evidence, shows that is helpful in that difficult time?
So some of the things that we've found in the past is around support networks. So we tend to find people tend to have better outcomes in terms of mental well-being when they have not the number of people in their social support network, but actually the quality of those relationships. So if you feel, for example, if you've got a wife caring for a husband who has, good support network in terms of, say, she may have siblings or children and grandchildren, and she has good relationships set up and in place for that, we tend to find that tends to help. From a more sort of healthcare service practice viewpoint, it's again going to this idea around discussions and making decisions. And being well prepared and well informed. And as I said, we don't do it well enough. And I appreciate obviously the pressures on the healthcare system. But what it is that if somebody has been prepared that dementia is a life-limiting illness, they may experience these symptoms going forward. This is what the later stages of dementia may look like. These are some of the decisions you may need to make. It's good to have those conversations, and it's really around the conversations with the person living with dementia. We definitely tend to find that the outcomes are much better when family carers have had the opportunity to have not just one, but continuous conversations with the person living with dementia for as long as they've got capacity to be able to make decisions and have discussions around the wishes and the needs of the person living with dementia with the support of a healthcare professional. So it's around sort of being informed, being able to make informed decisions, knowing the wishes and the needs of the person living with dementia, and having a good support network around them. We tend to find sort of results in good outcomes in terms of, say, depression, anxiety and stress for carers.
It's interesting you say that with the social support, because reading through your work, and I came across this term sandwich carers phenomenon, which actually a previous guest, Jacqueline Sin, introduced me to. She researches into the carer experience of people with severe mental illness, but this idea that if you're caring for someone with dementia in this case, but you've also got kids of your own, there's a huge almost pressure placed upon you to care for multiple people. And I can imagine that although social support is protective, it can be difficult to integrate that when you're caring for so many people at once.
Absolutely. And this is why we're saying that, this is the generation, and going forward, the future generations that are going to be the most impacted. Because we're living longer, the number of sandwich generational carers are going to grow, because you tend to find if people are having children later in life. So we commonly have family carers who are caring for children who are under the age of 18, for example, who are still living at home, they're still working. We've got people who are still working full-time jobs and trying to care for a parent or even a partner. And yes, this idea around sandwich generation, it's a lot of responsibilities. Some of my work looks around sort of passion and compassion fatigue, and this idea around that actually, because they are so overwhelmed by not just the responsibility of being a carer, but also the responsibility of other aspects of life, for example, children, having a job, running a household, for example. These all impact on a family carer's experience. We know it can be really rewarding. It's incredibly rewarding, but that definitely adds additional challenges.
Yeah, I can only imagine what that's like to have to go through. And another, I suppose, decision that some of these carers I know have to go through that I can't begin to imagine what that's like and the challenges that they face is regarding placing their loved one in a care home. So can you give us a bit of an insight as to what that's like? Because I know you've done a bit of qualitative research into looking at carers who have to make some of these decisions.
Incredibly difficult. And what we find in our work actually is that a care home placement commonly comes following a crisis. So you tend to find, a person's dementia or condition has progressed. They're no longer able to live independently at home. They may have experienced a fall, for example, at home, or their environment is no longer safe. We've heard stories of people leaving the gas on the hob, which is very obviously dangerous for them and those around them. And so you tend to find that what commonly happens is there is a crisis. It could usually resulting in like an unplanned hospital admission. So the person living with dementia ends up in hospital because they've become very unwell. And then healthcare professionals have to have conversations with family carers to say, if this person is living on their own or they're living with you, but you are not able to provide 24-hour care because that is what they now need, then family carers have to make that really difficult decisions around home placement. And that again, we were talking about earlier around the trajectory of dementia and how it's sort of, there are milestones within it. And one of the milestones is this idea around care home placement. I think it became quite complicated during COVID. We found that actually a lot of family carers were avoiding sending their loved one to a hospital, or trying to keep them at home as much as possible. And as you can imagine, it was an incredibly stressful period, both for carers whose loved one was already in a care home or those who were caring at home, because obviously the way we lived changed. Everybody, everything changed about how we lived our daily lives. And that became incredibly stressful because a lot of family carers reported that they were no longer able to visit the person they were caring for. We heard of stories of family carers not seeing their loved one for 3 to 6 months, or being able to see them through a window. And that was incredibly challenging. And even things around having to make difficult decisions without being able to see the person. Getting a phone call saying the person you're caring for has become really unwell from the care home, for example, and told, can we send them to hospital, and having to make those decisions over the phone without being able to see the person was, the stories we heard sounded incredibly difficult.
Yeah, when I think about it with my own parents, Nuriye, they're getting on. They don't have dementia or any major physical or mental illness, which I'm very grateful for, but their health is ailing somewhat. But some of these decisions about how I think I would like the care for them if it came to it, if they had dementia or some another major debilitating condition or illness. And I think idealistically, I would love to care for them in my own home forever. And sometimes I look at others who place carers in a home, and my immediate thought is, how could you do that when they've cared for you at your most vulnerable? But the other side to it is that sometimes it's the best thing for them, right? In terms of they can be a risk to themselves without that 24/7 care, like you alluded to, and a risk to the people around them if they don't have that professional care which you can't provide at home. So often it's not a selfish decision of, I'm so fatigued caring for them. It's what's best for that person suffering or that person going through and living with dementia.
Absolutely. And, we hear it from family carers who say, I had no choice. There wasn't really a choice in my situation because, like you said, I couldn't care for them at home. Even those who were not working, we've had family carers who are retired, caring for a partner, and they could not keep them safe at home. And that is the main thing. That's what it comes down to, is being able to keep them safe at home. It's also down to symptom management. So as dementia progresses, people will present with different symptoms. We hear, agitation and distress and pain can be a problem. And actually family carers, one, don't feel confident in being able to manage those. Two, not being able to have the right resources or the medications, and not knowing that they could ask for certain things. Whereas especially with a nursing home setting here in the UK, you have a registered nurse that's on site all the time who can detect those symptoms, and they have access to GP practitioners, sometimes geriatricians, sometimes even palliative care healthcare professionals who can come in. So as soon as a care home nurse recognises that this person might be experiencing something, or it seems a bit more agitated, seems a bit more distressed, they can put the right things in place to be able to address those symptoms and to make sure that that person isn't, distressed or agitated. Whereas family carers don't have, one, they don't feel confident sometimes. Two, they don't know how to ask or what to ask for. Sometimes they may not be able to detect it. Things around, and I'll give you an example, especially towards the advanced stages of dementia, sometimes people may not present pain in the way you and I might present pain. For example, we would say, ouch, or, oh, my tummy hurts, or something. Whereas if somebody is not able to communicate their needs, they may demonstrate pain in other ways. Like, especially, for example, we find when somebody is at rest, so somebody's sitting on a chair or lying down, they seem quite comfortable, but as soon as they're moved, for example, say they're given some sort of physical care, they're moved, say, in their bed, they might present some vocalizations, their face may grimace. That is an indicator that somebody is in pain. Care home staff tend to be trained to be able to detect that, whereas we as family carers at home may not be able to recognise and address that as soon as sort of seeing it, really. So it's around symptom management and making sure that that person living with dementia is not in any distress.
So they often can't verbally communicate what's going on for them and that they're even in pain. So you almost have to read into that and be able to detect that. That's kind of what you're getting at, hey?
Absolutely. Yeah, it's being able to know what to look for. More importantly, it's been able to say, they might, even though they can't tell you that they are in pain, you might notice certain things that might change. Last week they may not be making any vocalizations when you move them from their bed to a chair, but this week they are.
Yep.
There might be something going on.
So you bring up nursing homes, care homes, Nuriye, and one of the big revelations I had, again, reading through your work and the work of others in the field, is that care homes, nursing homes can be a really challenging place, both for those living with dementia and for the staff, however well trained they may be. And there are, a lot of challenges in terms of caring for people with dementia in those facilities. Can you give us an insight into what some of those challenges are?
Yeah, of course. So in particular with dementia, as we said, it's quite complex. People present in different ways. People are not able to communicate their needs. It's that whole idea around when you've got a little baby and you're constantly second guessing what's going on here. Why are they crying? Why do they seem a little bit agitated? It's, give them some water, change their nappy, give them some food. And it's around sort of trial and error. And with care homes and nursing homes, as we said, as well as they are trained, they do still find it quite challenging to manage some of the symptoms of dementia. Obviously, within a nursing home setting, you have a registered nurse on site, and their access to external healthcare professionals such as a GP or a geriatrician or even a psychiatrist is all external. So it's around detecting where there might be a particular symptom or need that's arised and knowing who to go to say, I need some support here. I need a psychiatrist to come in because I think this person doesn't seem as smiley as they normally are. Even though sometimes people with dementia, they're still still sociable, like smiley and trying to communicate in their own way. They're no longer able to do that. What's going on here with care home staff? Again, it's similar to family carers. They sometimes don't know who to go to for support, and it's knowing what, and it's basically trying to understand. Once somebody's lived in a care home for a little while, care home staff are much better at being able to detect changes. I guess that initial, when somebody first moves into a care home, the environment change can be quite distressing. So, being moved from, say, living with your family or living on your own in your own environment to then moving to a care home can be quite challenging. Care homes are communal spaces in terms of there's other people living with dementia. It might be noisy, it might be hot. In terms of the way the care home is decorated, like down to the carpet, for example, can be quite disorientating for the person living with dementia. And it's all down to the care home staff to be able to manage these difficulties on top of all the other sort of care that they provide for people living within care and nursing homes.
They must have to be quite technically proficient in terms of being able to detect what's going on and being able to work with people living with such a complex condition as well, all the unpredictabilities, the variabilities. So that level of skill must need to be at quite a high level.
Absolutely, yeah. And I think it's not, we've said this before, some of the barriers are around, and I don't know if this is similar in Australia, but in the UK, care homes tend to have a very business model. They do try their best, but unfortunately it does come to, it's a business at the end of the day, and so they have to be financially viable to be able to run. And so in terms of, we've worked with some really great care homes who have put in great training, who have welcomed research, who want to improve and empower in some ways their staff to be able to manage these complex conditions. But again, it does come down to, and one of the things that we find and what a lot of care homes say is we work very much in silos. We work on our own, where we're sort of isolated outside of the healthcare system in some ways. We have to get external help whenever we detect there is something going on with one of our residents. We have to know what that is. We have to know where to take that to and be able to have somebody coming in. I'm not sure how it works in Australia, but in the UK, you tend to have a local GP who's assigned to a care home. So we've worked with care homes in the past where they've had a GP that comes in once a week and reviews the residents. I mean, unfortunately, again, it's down to resources and time. They don't have the time to review absolutely everyone every week. They tend to just try and focus on, so this person's medication is running out, or this person seems a bit more agitated, or this person seems to have a bit of pain, or this person had a fall and we need to manage, that. And so they focus on, again, going back to this whole crisis management. Unfortunately, because of time and resources, they tend to put input when there is something has happened, rather than trying in some ways proactively being able to make sure that somebody doesn't have a fall, or making sure that somebody has painkillers on site that they're able to be prescribed.
I imagine continuity of care is so important, whether it's from the nurse inside the nursing home or the same GP that visits you, to ensure that they are able to see how someone is progressing in terms of their condition, whether they're deteriorating at a faster rate, because again, coming back to the fact that it's so unpredictable and everyone presents in different ways, that continuity of care to know what someone's current baseline is like, if you like, against someone who is perhaps deteriorating at a quicker rate must be so crucial.
Yeah, absolutely. And it's continuity of care, but it's also sort of integrated care in terms of different multidisciplinaries coming in. And we've worked with some great care homes who have monthly meetings, and they get different healthcare professionals. So within this MDT, multidisciplinary team, there was a geriatrician, there was a palliative care community nurse, there was the GP, there was the care home nurse. So they're all working together, and they're having regular meetings to review patients with complex needs, and to being able to, I guess in some ways, detect need before it happens, so that care is designed in a way where that if a need was to arise, to be prepared to be able to meet that. And it's getting those professionals in one room it works wonders, because they're all able to throw in their expertise and say, look, from our perspective, this is what we think might help, and being able to discuss and make a plan going forward, it's really crucial, to be honest. It doesn't always, but that would be what would be recommended, is being able to get all professionals who support and care for older aging adults with dementia who have complex needs, being able to sit together.
In terms of multidisciplinary treatment and care, Nuriye, one thing that really came up reading again through the literature is hospital care can have a really pivotal role and often, unfortunately, in a negative way. At least that's my impression, and again, curious to hear your thoughts. But a couple of quotes that I came across from a Denning et al. 2015 paper, I wanted to kind of put to you just as a way of colouring this in. So a GP who was interviewed said, send an elderly patient with dementia to hospital and they will probably die. Accident and emergency is not the place for such patients. And a carer whose father passed from dementia said every time he went into the hospital, he deteriorated. Now, obviously, this is presenting one side of hospital care, but to me, the impression was that hospital care can really not be the place for a lot of people with dementia and should be avoided where possible.
There's sort of two sides to this. Some people who say, you know, and I think this is my perspective in terms of, I don't feel that all hospital care should be ruled out for people living with dementia. If somebody needs a certain type of treatment that is not being able to be provided in the community, in their own place of care or place of residence, then yes, hospital admission is what is needed. You know, if somebody has a fall and they're in great pain, and that pain is not managed well in the community, you wouldn't want to refuse them a hospital admission because you're worried about their deterioration, because you want to make sure that they're not in pain. You're right, yes, absolutely. People who do have an unplanned hospital admission, they can deteriorate. And actually what we do know more recently from sort of large, from analysis of large data sets in the UK, is that people who have an unplanned admission, 2 or more generally, is an indicator that somebody may be nearing the end of life. So it's sort of that cause and effect, isn't it? Is it that that person dies in hospital because they've gone to hospital? Or actually, is it that they are at the end stages of life and therefore they've gone into hospital? So it's difficult to detect. But I do agree, you know, hospitals can be really disorientating. They can be, you know, the noise, the smell, being in an unfamiliar environment, you know, healthcare professionals who you're not familiar with. And so while we say, you know, ideally you want to try and provide them care in the community, in their usual place of residence, it's just not always possible. And so in that situation, yes, hospital care is the best place for them, but it's around trying to care for them as well as they can in hospital and being able to say, okay, you're now ready to go back into meeting your place of, you know, your usual place of care, and to be able to continue that care there. And I guess this is sort of going back to your idea around this conversation around continuity and integrated care, and that continuous conversation is, we know that it doesn't always happen so well where somebody is discharged from hospital and they return back to, say, their home or a care home. And that conversation between healthcare professionals in a hospital, being able to, you know, make a plan and say to the care, right, you need to do these things to make sure that this person stays well. We know that those conversations don't always happen. And then the other difficulties we have around discharge from hospital is that if, for example, somebody goes from home to hospital, but they are it's no longer safe for them to go back to a care home, they may end up spending more time in hospital than necessary. So they're well enough to leave, but they're unable to leave because there is not a suitable place of care. Because, you know, they say, for example, family carers are trying to find a suitable care home that has a space to take them. That can be quite challenging. So in terms of, you know, in an ideal world, it would be that if somebody needs hospital care, that they get that hospital care, but they get it in a timely manner and they return to the community as soon as possible. But these things, unfortunately, don't always happen. So I'm sort of from a perspective of, I'm not saying that we should rule out, all people living with dementia should not go into hospital. I think where there is a reason that their needs are not able to be met in the community, they definitely should receive hospital.
Why are so many people living with dementia placed into hospital? I was reading it from the NICE UK website. 25% of all hospital beds in the UK at any one point in time are being used by people living with dementia, and I thought that can't be right. Why is it such a high number?
They have complex needs. They're not able to communicate their needs, and therefore when somebody is unable to communicate their needs, the care that's provided in the community is not able to address those, unfortunately. You know, so if somebody is quite distressed, but you don't know what is causing that distress, then they're more likely to go into hospital. Or say they're having a symptom which then is made worse over time because that symptom is not being addressed because people around them, whether it's family carers or professional carers, are not able to detect that there is something going on, and then that becomes worse, and then that requires a hospital admission. We go back to this we compare it to cancer, which is very, very different, where the person is able to communicate their needs. They're able to access care in specialist hospitals to be able to have their symptoms met. They become better, they leave, they may need to come in for other symptom management, but with dementia, that process doesn't really exist. It's usually, again, it's going to this idea around crisis management. Crisis happens, then that person is hospitalised, and then sometimes their symptoms they deteriorate, and therefore they spend. It's also around they spend a long period of time in hospital. They're not in and out very quickly. Unfortunately, they do spend long periods, which also then impacts on their symptoms as well.
Yeah. I think the overall message I'm getting from what you're saying, Nuriye, and again reading through everything, seems to be that people are doing their best, carers are doing their best, the caring environment in terms of professionals are doing their best, but there really are a lot of gaps and a lot of places for improvement for care for people living with dementia.
And I guess that's where I'm hoping that this is where our research will sort of fill that gap in some ways. Looking at dementia from a very palliative care perspective is advocating for and is saying, when it's around being proactive in anticipating need rather than crisis management. It's saying somebody living with dementia who may have other conditions, this is what their symptom or their need profile may look like in future, and we need to make sure that we anticipate, or if we start to see signs that they're having some sort of symptom, to be able to address that, and making sure that it's not getting to a point where they then need, to be hospitalised, or that it becomes too difficult to manage it in the community. So I guess what I'm saying is I think a palliative care, what we don't know actually is whether or not is that actually are we thinking about more of a newer profession in terms of specialist dementia palliative care teams, to people who are palliative care teams that specialise in dementia, or actually are we trying to say that generalists should be trained to offer palliative care for people living with dementia and their carers? We're still not sure. So we're not entirely sure what would be, because so many people are living with dementia. The specialist palliative care teams tend to be quite small, especially in the UK, and so the support that they can provide, they can only provide care to a smaller population of people. Whereas actually, are we saying that like GPs or other healthcare professionals need to be in some ways upskilled or offered training in palliative care specific to dementia to be able to provide that care and to fill that gap?
Yeah, and in terms of the gap about communication, Nuriye, you mentioned that a significant percentage of people 18 to 30 have misconceptions about dementia. There's this perhaps lack of understanding about the importance of having early conversations if you're a carer, between the carer and someone living with dementia. I'm curious, how do you plan on effectively communicating that out so as to change those misunderstandings and misconceptions and to affect real behaviour change, i.e. people having these conversations earlier on, being proactive? What's the method that you're going to go about that? Yeah,
raising awareness. I think this is what it comes down to. The next generation of people who are going to be most affected by dementia. It's about raising and improving their understanding of dementia. And it's working with larger organisations. We as researchers can't do that on our own. We need policy input. We need policies to say we need to raise awareness. We need to work with campaigns and do campaigns that say, yes, you can live well with dementia, but once somebody is diagnosed with dementia, they will die with dementia, and therefore it's a life-limiting condition. So here at the Marie Curie Palliative Care Research Department, we're funded by Marie Curie, the charity, and they are an end-of-life care charity who have hospices across the UK and who provide care for people who are dying all throughout the disease trajectory, including people who are living with dementia. And, one of the things that they want to do is they want to raise more awareness around palliative care for people living with dementia, and to be able to say, and I think it's around changing the narrative, really. One of the things we hear is a lot of the times, oh yeah, but people can live well with dementia. Absolutely, we're not saying people cannot live well with dementia. What we're saying is actually people will die with dementia, and it's being able to make that experience a positive experience, or an experience that's not going to have a detrimental impact on both the person living with dementia and their carers. Being able to say, again, around having conversations, it's a terminal illness. You will need to make difficult decisions to be able to make sure that the person, for example, dies in their usual place of care. We were talking about a lot of people die in hospitals, people living with dementia. And yes, that's very common, but it's how do we reduce that? If somebody is able to die peacefully in, say, their usual place, whether that's a care home or in their own home, how do we make that happen from the beginning, rather than waiting for somebody who's at the dying phases, who's in the last couple of weeks of life? How do we make that happen? It's raising awareness, it's improving knowledge, it's saying, the next generation of carers or people living with dementia, it's about them knowing, okay, now the person I'm living with is in the last phases of life. How can I keep them comfortable at home? What services can I access to support me to do this? So it's all around raising public awareness, and it's working with larger organisations and the government, really, to be able to do that.
Fantastic, Nuriye. And certainly in terms of raising awareness, the majority of listeners to this particular podcast are in that 18 to 30 age range. So I think certainly some understanding will have been developed from people listening and tuning in. And on that note, is there kind of anything finally that you wanted to convey to people listening, any particular points that you wanted to get across that you think might be a benefit?
Yeah, absolutely. Again, you've highlighted the importance of the next generation, and that improving their understanding of dementia and what it might look like. And we're all in some ways going to be impacted by dementia because we are living longer. The positive side of living longer, unfortunately, the other side of it is that we will have health conditions like dementia, and it's just understanding and being able to access the right support when you need it. And I think that's the most important thing. And it's about knowing how to support somebody who's affected by dementia, whether or not you're supporting a carer of somebody living with dementia, or whether or not you're caring for someone living with dementia. That knowing and understanding dementia, I think that's really, really key for the next generation.
Thanks for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means that you've either gleaned a ton of value from this episode or that you've fallen asleep. And I sincerely hope that it's the former. If it is, I would be so grateful if you were to hit subscribe, follow, or share this podcast with someone you care about. My mission is to communicate evidence-based wellbeing strategies that are really accessible to people in an accessible format and resource the world over. You sharing certainly helps us to hit that mission. Thanks so much for tuning in. It really does mean a lot that you do listen or watch, and stay tuned for next week's episode on the Mental Wellbeing College.